Integrated trauma treatment for PTSD. There are several components that are essential to being a therapist. First, one needs to have empathy, the ability to walk alongside the client through periods of pain and discomfort, as well as the ability to have compassion, which is empathy with the added component of the desire to alleviate the pain experienced by clients. In addition to these, it is important for a therapist to have unconditional positive regard toward their clients and the ability to offer hope. It is a privilege as a therapist to sit with people who are hurting and vulnerable. Clients trust therapists to hold their secrets until they are able to share them themselves. Yalom said, "We are cradlers of secrets." It is a profession that is defined as being a healer, but it is also a healing experience to lay witness to pain, growth, and transformation of others. It is often considered a calling and has the potential for the exploration of all aspects of a person's life, including a faith component. It is my personal desire as a therapist to help those who are hurting within the adult population, helping couples with relationship and communication issues, or helping families, as well as adults in a variety of life stages, such as the elderly. It is also important to me that I consider multicultural issues. The Christian cultural group is highly underserved in my area of the country, therefore I would like to address these needs as well as those of military, veterans, and first responders. I also would like to consider multi-country contexts and the needs of those in other parts of the world. To meet the needs of these various groups, it is important that I am willing to meet each client where they are at. Irving Yalom once said, "The therapist must strive to create a new therapy for each patient." 1 Corinthians 9:22 furthers this sentiment by saying, "I have become all things to all people, so that by all possible means I might save some." Therefore, my approach to therapy is an eclectic approach, where I draw upon the theoretical bases of several different approaches. The first component of my theoretical basis is that of Carl Rogers' client-centered therapy. In this, he focuses upon unconditional positive regard toward clients, believing in the person that is sitting in front of you. Also, the concept of being non-judgmental toward clients, really accepting them for who they are, that the person is who is being treated, and not the problem or the diagnosis, but the person themselves. Also, his concept of congruence is very important to me. The idea of being a genuine person in front of our clients, that they would receive this genuine experience in the therapy room. And also the belief in the client's ability to heal. Another aspect of my theoretical basis is acceptance and commitment therapy. ACT is a third-wave cognitive behavioral therapy developed by Stephen Hayes in the 1980s. According to ACT, the purpose of life is not to be happy, but rather to matter or be productive and useful, and to have it make a difference that you've lived at all. ACT promotes an acceptance of difficult psychological states that are out of a person's control, while committing to act in a way that incorporates their values and beliefs, and taking action toward this meaning in life. According to Stephen Hayes, ACT is not about training the normal mode of the mind. It is about getting out of your mind and into your life. It is to create a rich and meaningful life while accepting the pain that inevitably goes with it. To change the relationship between the person and their thoughts, feelings, and experiences, as well as to develop psychological flexibility rather than the fusion of negative thoughts. Mindfulness is also a third-wave behavioral approach that has been found to be effective at treating a wide variety of diagnoses, and it integrates well with other approaches. For instance, ACT uses many mindfulness components. It builds distress tolerance and resiliency through teaching skills that promote a mind-body-spirit connection. It increases awareness of self and others and an acceptance of the self, and as well as an ability to be present in the moment in a non-judgmental way through the use of exercises and meditations that are practiced usually daily. When considering approaches that will address trauma in clients, it is first important to understand that trauma can come in many forms. The human experience includes suffering on several levels. Trauma can come in the form of big T traumatic events that are intense or life-threatening, such as combat experiences, torture, rape, assault, abuse, violence, terrorism, or natural disasters. Any of these can lead to symptoms that can result in post-traumatic stress disorder. Life also includes experiences of small t traumas, where a person feels shame, humiliation, embarrassment, or pain from upsetting, hurtful daily events. These non-life-threatening experiences can interestingly have similar affective results as big T traumas and can have lifelong effects on a person when untreated. Eye movement desensitization reprocessing, or EMDR, an approach that will be discussed shortly, addresses both of these kinds of trauma. Post-traumatic stress disorder, or PTSD, is a diagnosable mental health condition in which a person has been exposed to big T trauma, and they are experiencing intrusion symptoms such as flashbacks or intrusive thoughts. They are also experiencing avoidance symptoms such as avoiding people or places that remind them of the event that they experienced. The person also experiences negative alterations in cognitions or mood, and alterations in arousal, such as being hyper-vigilant when in the community. And in order to be diagnosed with PTSD, a person must be experiencing these symptoms for at least 1 month. Two approaches to trauma that can be integrated into my current eclectic theoretical base are eye movement desensitization reprocessing, or EMDR, and internal family systems, or IFS. EMDR was developed by Francine Shapiro and her adaptive information processing model. This model advocates that the brain has a natural capacity to process the daily life experiences and integrate this information in adaptive ways. However, if negative information or experiences are stored maladaptively, this information can get triggered by other life events. Dysfunctionally stored memories can create problems in functioning because future responses can therefore be maladaptive themselves and become the basis of psychopathology or other mental health symptomology. However, she found that this maladaptively stored information can be successfully reprocessed and consequently adaptively integrated. There are 8 phases of EMDR treatment. The first phase is client history and treatment planning. Although details of the trauma do not need to be discussed, a thorough history of the client is gathered, including trauma history as well as medical history. Some medical conditions, such as significant cardiac issues, are contraindicated for EMDR treatment because in about 10 to 15% of the cases, clients intensely re-experience their trauma. Therefore, it is important to determine the appropriateness of using this modality. The presenting problem is identified, as well as the target traumatic experience and associated negative cognitions. Finally, a treatment plan is established. The second stage of EMDR treatment is preparation. The preparation phase is of the utmost importance because trust in the therapeutic relationship is established in this phase. The clinician offers a thorough explanation of what EMDR treatment is, as well as the expectations of this treatment. The clinician teaches relaxation techniques so that the client is able to self-soothe during the treatment. And testing of the bilateral stimulation that will be used to reprocess the negative information occurs during this phase. In the third phase, assessment, the traumatic memory is accessed and the aspects to process are identified. The person is asked to recall an image or statement that best describes the worst part of the event, as well as the negative self-belief that is associated with this. Then an alternative positive belief, which the person would like to hold, is determined. Using a 1 to 7 validity of cognition scale, the person then rates this positive belief, ranging from completely false to completely true, and rates the distress of the target event on a 0 to 10 subjective units of distress scale, ranging from no distress to maximum distress. During the fourth phase, desensitization of the traumatic memory occurs. The clinician asks the client to bring to memory the target event as well as the negative cognition associated with it and any current distress the client is experiencing at bringing up this memory. The therapist then administers the bilateral stimulation, usually in the form of horizontal eye movements, but also can be in the form of tapping or auditory stimulation for about 30 seconds. The client then states any automatic associations that are noticed during this, and distress is measured on the SUD scale. Several sets of bilateral stimulation and verbalization of associations occur until the SUD measures little to no distress. When little to no distress is experienced when recalling the target event, the installation phase begins. The alternative positive belief is strengthened and installed using bilateral stimulation. This is continued until a high score is achieved on the validity of cognition scale. It is important to note that a person cannot install inappropriate beliefs. The brain will reject these. EMDR is a therapy in which the client maintains control of the process throughout, and the therapist offers support and reassurance along the way. Once the positive belief is installed, a body scan is performed. The client is asked to recall the target traumatic event and to identify any residual body tension associated with it. This tension is reprocessed using bilateral stimulation, and this process continues until the tension is completely resolved. It is important in EMDR for the client to leave each session experiencing an improvement in symptoms. To this end, during the closure phase, the therapist reviews the self-calming techniques that were learned or used during the process. A goal of EMDR is for the client to experience an ability to be attuned to and care for themselves. Also during this phase, the clinician explains what the client can expect between sessions. For instance, further reprocessing may organically occur, and sometimes strategies such as journaling may be beneficial. Many clients experience a need to rest after an EMDR session. The final phase, reevaluation, occurs at the beginning of each subsequent session after the first. It is important to assess the maintenance of progress throughout EMDR treatment, and this phase does so through measuring scores on the SUD and VOC scales, as well as through a body scan. This gives the client and therapist an opportunity to determine any further areas of treatment, as well as make any adjustments. Phases 3 through 8 are repeated until EMDR treatment ends upon the resolution of the presenting problem. Although not the primary goal, EMDR can produce rapid results, with many clients seeing full resolution of symptoms without side effects within a few sessions without reemergence of symptoms. Therapists administering EMDR convey acceptance and non-judgment, are reassuring and supportive in their approach. Common questions or statements used by these clinicians while doing the bilateral stimulations are, "What are you noticing now?" "Go with that." "Keep noticing." While administering the SUD scale, a clinician may ask, "What keeps it from being lower?" Or when administering the VOC scale, "How true is this statement now?" Much like my original theoretical base, EMDR is an eclectic approach in that it uses a variety of components found in other therapies as well. Similar to client-centered therapy, it upholds a belief in a client's ability to heal, has a goal of the client caring for themselves, and similar to ACT and mindfulness, it strives to increase awareness and acceptance of the self. EMDR and mindfulness have both been shown to decrease the vividness and intensity of traumatic memories due to brain responses to these approaches. EMDR also demonstrates an ability to integrate faith components. The therapist is trained to accept the strengths presented by the clients, and if clients' automatic associations include aspects of faith, then these will be processed and installed as part of the positive beliefs or coping skills. Internal Family Systems, or IFS, was developed by Richard Schwartz and has been expanded by J. Early. IFS states that all people encounter a natural multiplicity of the brain in which various parts or inner voices are experienced. This is only experienced as dysfunctional if the parts become overly fragmented. IFS advocates for an acceptance of the parts with a goal of obtaining balance and proper functionality of the parts through self-leadership, in which the core self of the person is able to direct the parts rather than the parts working to hide experiences from the self. There are three main parts defined by IFS: the exiles, the protectors, and the self. Each part plays a different role, and regardless of the current symptoms, these parts each have value and good intentions. Exiles are often the young, most vulnerable, sensitive parts of a person. These are the innocent parts, most susceptible to injury, and tend to hold the painful or traumatic memories, especially of early experiences. When these parts become overloaded with pain, they can be hidden away as a way to avoid facing this pain and to give the self distance from it. Like a small child, these parts can become emotional when triggered. Protectors come in two forms, managers and firefighters, and serve to shield the exile from exposure and maintain distance between the pain held by the exile and the self. Managers are well organized and function as guards of the fragile exiles to avoid upsetting them. They also work to preserve a positive appearance or perception of the person. As such, they can be perfectionists, procrastinators, people pleasers, overly productive, passively pessimist, and can often be the most significant inner critic. When managers are unsuccessful or at risk of being unsuccessful at keeping the exiles hidden and the self protected from the pain carried by the exiles, firefighters are activated. These parts protect by dramatic and often toxic means of dousing, distracting, or dissociating from the pain, such as risk-taking behaviors, addictions, overworking, overeating, gambling, or overspending. The self, with a capital S, is both related to and separate from the other, more extreme parts. This part is the true, core, inner, balanced, leading part of the person that exudes the 8 C's: calm, creativity, courage, confidence, compassion, connectiveness, and is curious and offers clarity. This self is the true leader of the person, and the goal of IFS is to restore the inner self-leadership by raising awareness of the various parts. The self can then release these extreme parts from their inappropriate leadership roles and establish the leadership of the self. In doing so, the self, who is separate from the parts, can serve as a co-therapist and attend to the needs of the other parts. IFS is a collaborative approach in which the therapist acts as a coach or a guide and the client is in control of the process. The clinician offers reassurance throughout the treatment, and the goal is to improve the functionality of the various parts and the security of the person by establishing self-leadership. A therapist using IFS employs questions to empower and guide the client. For instance, it is important that the therapist ask permission of the protective parts before approaching the painful parts. A common question to increase awareness in this modality is, how do you feel toward that part? As in ACT and mindfulness, improved awareness, acceptance, and a non-judgmental stance is used to promote change in IFS. The goal of person-centered ACT as well as IFS is to achieve a fully functioning person who is capable of caring for the self, and this is achieved through a collaborative and genuine approach. Like the other aspects of my eclectic approach, IFS also demonstrates an ability to readily integrate with a faith perspective. One researcher, Holmes, observed that spirituality was readily connected to using IFS and that our ability to activate and join with spiritual resources is a major step forward in terms of empowering the self-regulating capacities of our clients' internal systems. This eclectic approach is readily integrated with a Christian worldview. The concept of unconditional positive regard is demonstrated repeatedly in the Bible, such as in John 12:47, where Jesus explains, "For I did not come to judge the world, but to save the world." And in Luke 15:11-31, the story of the prodigal son. Despite the negative, self-destructive, and hurtful behavior of his son, the father believed in his son's ability to self-regulate and had compassion on his lost state. In verse 20, where it says, "But while he was a long way off, his father saw him and was filled with compassion for him." Compassion is a core characteristic of God, as in Psalm 145:9, where it states, "The Lord is good to all, he has compassion on all that he has made." Therefore, approaches that incorporate a sense of belief in and compassion for clients demonstrate the same change mechanism employed by God. Acceptance is also a foundational Christian construct found in this eclectic approach, incorporating client-centered ACT, mindfulness, EMDR, and IFS modalities. As is stated in Romans 15:7, "Accept one another then, just as Christ accepted you, in order to bring praise to God." All aspects of this approach also call for the therapist to be genuine and relational rather than a blank slate. The core of the Christian worldview is a belief that God is a relational being who seeks a relationship with his creation, and when Christians have experienced trauma, Psalm 34:18 shows God's response. The Lord is close to the brokenhearted and saves those who are crushed in spirit. Awareness and mindfulness are components of each part of this eclectic integrated approach to trauma treatment, and this too is supported by the Bible, such as in Psalms 26:3, where it states, "I have always been mindful of your unfailing love and have lived in reliance on your faithfulness." Lastly, each of the modalities in this approach leaves room for the healing power of God. EMDR and IFS are both directed by the client and the material they bring to the trauma work. Clients who see faith as a healing component are welcome to bring this into either of these processes. Additionally, ACT asks clients to define their values and to move toward these values. Client-centered therapy is also directed by the values of the client, and mindfulness can be used to help clients access deeper aspects of their faith through specifically Christian meditations or raising awareness of the presence of God in the healing process. Isaiah 9:6 describes Jesus as the wonderful counselor. Approaches that make space for and invite this power are better equipped to meet the needs of Christian clients. This eclectic integrated approach to trauma treatment incorporates client-centered, ACT, mindfulness, EMDR, and IFS therapies for the therapist to draw from in helping vulnerable clients. Having access to each of these modalities equips the clinician to meet each client where they are at and to offer a path toward healing and wholeness despite difficult life circumstances. It also leaves room for the Holy Spirit to work in the lives of the clients and for the clients to openly explore this aspect of their healing should they want to.